the best pieces of advice I ever got from a mentor was to put a lot of stock in the signs and symptoms that you find that do not match what you think would match your provisional or hypothetical diagnosis at that time. That is, pay attention to the things that don't match. Most clinicians, I think, either because they don't know how to find all these signs and symptoms, or because they don't have the time, or they want to find a diagnosis as quickly as possible, they will really focus in on the things that make sense. And unfortunately, I think a lot of signs and symptoms that are collected that don't match will just be ignored. And of course, a lot of them will be explained away with my least favorite word in orthopedics, which is compensating. I give patients this example all the time. If you have a cold, you're lethargic, you are maybe a little feverish, you are coughing, you are sneezing, and your eyes are bleeding, that's not a cold. And I think in orthopedics, the analogy would be, they would say something like, oh, well, your eyes are bleeding because you're coughing so much. You're compensating, or something along those lines, maybe not using the exact word compensating. But I think that's insane to do that for someone like that. Obviously, they could make the leap, oh, you have a cold and separately your eyes are bleeding, and maybe that's the case, but that goes against one of my key principles as well, which is it's one problem till it's not. Meaning we're going to try to find the one diagnosis that explains all of the signs and symptoms before we're going to tease these apart into different diagnoses or a primary diagnosis and just other findings that are unrelated. So I would suggest that you don't think of this as someone who has a cold and who has a bleeding eyes problem. I would suggest you would think about a diagnosis that fits all those symptoms I mentioned and any signs that you may find via a clinical physical exam or a clinical testing model, anything along those lines. But in orthopedics, I think we're doing that all the time. And again, I think we're using the word compensating a lot to describe things that really aren't compensating phenomena. If your diagnosis is a tight muscle on the right side of the neck, let's say the upper trap or the SCM, I don't really find a tight muscle is going to be a root cause diagnosis, hardly ever, if ever. But say that's the person's diagnosis. That's what the clinician thinks is the problem. Well, then going away, putting that muscle on full stretch will be limited and painful on that right side in that muscle. And by definition, going to the left or going to the right towards that tight muscle should be normal and should not be painful, because there's nothing about a tight muscle over here that should make going into that range a problem. So if you tested that simple thing and you found that, oh, I think you have a right upper trap tight muscle and that's causing all the pain on the right side of your neck, and you have them go into right side bend and it's limited or it's painful or it's both, well, that would say to me, that's not the problem, because a tight upper trap muscle on the right would not cause that. And again, I think you are largely finding clinicians that ignore that symptom or sign or don't understand that that's not how tight muscles present. Or thirdly, they'll say, oh, well, it's painful going to the right just because, you've had this problem for a while and it's just compensating. And I don't agree with those kind of three different paths where clinicians are just explaining away or ignoring signs and symptoms that don't match the specific criteria for a specific diagnosis. Another example would be a patient thinks and a clinician thinks the patient pulled their hamstring muscle. Now, there are very specific criteria for a hamstring strain. Say in the physical exam, we're also finding significant lumbar side glide loss toward that side. Say we're also finding weak hip flexion testing. Those are not corroborating a hamstring pull. Those are not consistent with a hamstring pull. And I think in so many scenarios, people are saying, oh, those are separate, or, oh, your hip flexor is weak because your hamstring is pulled and it's just having to do a lot of work and it's compensating and it's tired. Or you're missing lumbar range of motion significantly on that side, but that's unrelated. Or they won't even test lumbar side glides. At the end of the day, I really believe in this principle. You need to focus on the things that don't match, because they're usually the key piece of information that tells you the diagnosis you're thinking of is incorrect and you need to think differently. And again, if you don't have repeated movement testing as a possible orthopedic test to use, you're not going to even be considering that a mechanical joint problem in the low back is causing that posterior thigh pain, aka the hamstring strain, or that the cervical spine is lacking extension and therefore that joint is misbehaving and you're presenting with right-sided neck pain. If you don't have that as an option diagnostically, of course you're going to try to make everything fit into the diagnosis you have, because you have no other option. You have no other diagnosis to offer this patient. But you need to focus on the things that don't fit. You need to consider it's one problem before it's multiple, or it's one problem creating all these signs and symptoms before you consider it's one problem causing compensatory problems. And you need to consider it's one problem where all of those signs and symptoms that you find match that particular diagnosis.